Who's going to use bone when they go out? Structural allograft. Nobody's going to use bone. 2 people, 4 people going to use bone. Who's going to use metal? And who's going to use PEEK? Nobody's going to use PEEK. OK. So we're going to talk about anterior interbody implants. I have no disclosures relevant. So as you guys know, you can use structural autograft. Who's taking structural autograft? Iliac crest? Nobody. Structural allograft. And of course, there's interbody cages. In general, there's PEEK and there's metal, tantalum, titanium, et cetera. And we'll talk about those. Structural allograft, I guess over here. Structural allograft probably has the best data. Here's a good systematic review, looks at 22 published articles. Allograft turns out to be the cheapest, has good clinical outcomes, fuses well. So I think structural allograft is probably still king, no matter what the device companies tell you. I think there are nuances, and we'll go through those nuances. But you're never going to go wrong using structural allograft. OK, so while this goes up, structural allograft, I think, still has its problems. I used structural allograft for probably the first 5 to 7 years, only because that's how I was trained. And this is one of my patients from when I was back using structural allograft. This is his 3-month, then 6-month. And you can get this resorption of structural allograft, and I know we've all seen it. But there's no question that structural allograft isn't perfect. It does resorb, and often you have to treat the non-union. And so pseudos still happen. So biomaterials, there's basically PEEK, and there is titanium. PEEK is plastic, right? Has good Young's modulus. The modulus of elasticity, stress over strain, is very similar to cortical and cancellous bone. Stiffness is very similar to bone, but it's not good for ingrowth. As you guys know, it forms a membrane. It doesn't really grow in, and bone doesn't grow onto it. Titanium, just like they do for total hips, it can promote ingrowth, ongrowth. It's biocompatible. It forms an oxide layer. So it's very inert. And the problem with titanium is it's very stiff, right? So everyone talks about Young's modulus, stress over strain, and there's a varying degree of Young's modulus from PEEK to titanium. And the issue is, as it gets higher and higher in Young's modulus, you can get more and more collapse because the moduluses are different. So modulus elasticity sticks with the type of material, no matter what the construct is, which is different than stiffness. So a crowbar and a paperclip have the same Young's modulus. They're both made out of metal, but the construction's different, so the stiffness is different. So as time has gone on, people started doing 3D printing and started poking holes in metal to try to make the stiffness similar. So even though the Young modulus is still very high, the stiffness is better. Here's a retrospective review. This is John's paper. 120 levels titanium, 115 levels allograft at 1 year. Actually good fusion rates with metal and better subsidence with metal as well, so less subsidence with metal. And that's with these 3D printed cages. PEEK biology, as I said, PEEK is plastic. It forms a biofilm. This is a study look at human mesenchymal stem cells. They looked at it on top of PEEK, and they showed that you can get apoptosis. You get this fibrous tissue. And if you've ever taken out a PEEK implant anteriorly, and sometimes this happens from a non-union because you put a T-lift cage in, it's PEEK, and then the front, it just kind of pops out, and there's this kind of fibrous soft tissue around it. We all see this halo effect. However, with titanium, this is actually a Wellington slide. I love when he does this. Wellington is so scientific. So with titanium, there's lots of papers that show that you get upregulation of osteoblasts, you get BMP, and there's really good clinical studies now looking at porous titanium, scratch titanium that really have very good fusion rates. So this is looking at titanium versus PEEK versus allograft. They looked at the strength at 5 weeks, push-out strength, and titanium is better than PEEK, which is better than allograft. Surface modifications, now you start roughening the titanium, so you get ingrowth, ongrowth, and they found that with rough titanium, you get increased stimulation of type 1 collagen and even better fusion rates. And I think the real difference between PEEK and titanium is PEEK, because there's no initial friction fit, gives you this calloused bone formation like it is when you break a bone and you don't brace it. Whereas if you have roughened titanium and you have smoother bone growth, non-callous formation, it's like plating a bone. So for that reason, I tend to like titanium with roughened surface. People used to hate on titanium because there's artifact, particularly with tantalum, cobalt chrome. But here you can easily see that, and if you put in a titanium cage, you get a post-op MRI, it looks just fine. There's no real artifact. So I don't think imaging's an issue. I think the imaging is a problem when you're looking at fusion. These are actually both cases I did last week, very similar levels, and I tried 2 different cages. So this is a ATEC cage, that's an orthofix cage. And not all cages are the same. I mean, this metal cage, it's gonna be hard to see bone across. The cage over there, just because of the mesh design in the middle, you potentially could see bone grow across. So as you guys get into practice, look at the type of cage, look at the lucency of the cage, look at the stiffness, but not all metal cages are the same, and you'll have to figure out what works the best in your hands. Still, it's hard to evaluate fusion. This is Dan Rue's kind of famous paper looking at comparing CTs to flexion extension views. So, they said take a flexion extension X-ray and take a flexion extension X-ray, measure the interspinous process distances. If it's more than 1 or 2 millimeters, then it's a non-union. This is one of my patients who's 6 months out. And I think it's still hard to tell. Like for me, you can do this, but if you're really worried about a non-union, I go to a CT. So these are both younger patients, and you can clearly see on the left, there's no bone bridging across. There's a little bit of haloing around the metal. And this is another patient where you do see bone possibly on-growing onto the metal. You do see bone growing across. And frankly, when I'm looking at a non-union, I specifically look at the uncinate, because if you go really lateral on your approach, more often than not, you'll see the uncinate fill in before you see the interbody fill in. So I'll use that uncinate sign as something that documents fusion. This is probably the best part of metal. I think that trumps allograft, and it's the sizing. So whenever we used to use VG2, it really came maximum 12 or 14 deep. But as you guys know, the vertebral body can be long, particularly in bigger individuals. And VG2 only comes parallel or 7 degrees. So a lot of these cages now, they're 15-degree hyperlordotic, 15 by 15 implants, 17 wide. So if you go really wide, it used to be you put VG2 and you put it in, there's a whole bunch of space to the right and left of the graft, and you're like, this sure would be great to be able to graft this level. So I think the metal cages are particularly nice because of the footprint. And that, I think, is the main advantage of the footprint. What do you put inside the cage? I put DBM, I put Grafton. There's good data for Grafton, Osteocel, autograft, and I factor. I don't know of any other randomized trials that show good fusion with any other allograft. I'm not sure you even need allograft in a metal cage. The other thing about a metal cage is, again, not that billing's everything, but if you build structural allograft, it's 1.81 work RVUs, and you can't build times 3. So if you do a 3-level ACDF, you're getting 1.8 RVUs. Interbody cage, you can build 22853, more work RVUs, and if you do 3 cages, it's times 3. So this is another situation where actually, in my mind, trying to do the right thing is a good thing financially. The last thing is I'll touch on standalone cages. Anybody plan on using these? Nobody, 1 person, 2 people. Yeah, it's interesting. I've used them for adjacent level. Every time I use it, I see kyphosis. So I stopped using it. And maybe I'm just a bad surgeon for adjacent level and standalones, but I always see kyphosis. There's good papers that show that theoretically less adjacent level disease. I think if you put a short plate on, I don't think it matters. There's less dysphagia, less blood loss, but you do see in these studies some more subsidence, some loss of lordosis. And don't forget, if you put this in, you cannot bill for the anterior instrumentation. Anterior instrumentation is integral to the cage here, whereas it has to be independent. And I think there are some crafty companies now putting the cage out and like a little plate that screws onto the cage that in theory is separate, even though it comes together. So you can build 22845, that's 12 work RVUs. So yeah, that's that. That's interbody cages.
Any questions for Brian?
Any? Yeah.
In that example you showed where the interbody is going to absorb into this space and collapse again, let's say the patient has now redeveloped stenosis, really redeveloping from that. What do you do to treat it?
I do a posterior fusion and a framenotomy in the back.
And that's usually sufficient.
Yeah, it's interesting. Like I think if you look at, even if you do a good uncinetectomy, not the whole thing, but a partial, and you see that nerve root come up, you're doing an ACDF, and you see the upslope of the nerve, you feel the medial pedicle, you think you have a very good framal decompression. When you get a post-op MRI, like it always looks like shit, and it still looks stenotic. And I do think that over time, I know that over time as it resorbs, the osteophytes resorb and remodel. So with a non-union, I think often what happens is the osteophytes are not resorbing. And so I'll go to the back and just do a framenotomy if it still looks tight and put lateral mass screws in. Some people are using, what is that, D-Trax, like the little device that goes into the Anybody use D-Trax? D-Trax? Is that it's a little implant that goes into the, you do that for non-union?
I use a machine cortical allograft.
Yeah, do you have a microphone? I think that's interesting. Let's, it's a non-union, ACDF non-union. Like in the back, how do you fix an ACDF non-union?
Well, I put in, I use the interfacet space. I think it's a very valuable space to work in, but I use machine cortical implants that I pound in. I take out the...
No screws.
But I will use screws. I add the screw, but I think it is so firm that it could work. There is, the D-Trax paper I'm aware of doesn't tell you if it worked or not. They said, we did this in this many cases, and that's all they say. They don't tell you what the outcome was. So, but I believe it probably does work.
And will you do a framinotomy of still persistent radiculopathy?
No, because if you put that interspace distractor in, it will increase the foraminal area. So you indirectly open up the foraminal area, you have a graft in the back, pop some screws in, and you're done.
I'm curious what you guys' thoughts are on titanium-coated PEEK interbodies.
Yeah, I had like 5 slides on it, took them out because I had to give a 12-second presentation. So metal with PEEK shows very good on-growth properties, actually, and it's very similar to metal. The problem is you can shear the metal off of the PEEK, depending on the design. So there's a few studies that look at their in vitro studies with push-out where you can see the bone growing onto the metal, but then the plastic delaminates off the metal. So I'm not sure that the stiffness and modulus change is worth it when you can just use pure 3D printed metal.
It might be more of a research question, but obviously the density of a 70-year-old is different than a 30-year-old. Putting in a titanium, maybe for both of them. Are there companies or grafts available that have different densities that maybe can match?
I think you're thinking more stiffness, so different levels of stiffness, and not that I'm aware of. I don't think a company would say, you know, here is a cage A, B, and C, and each one has a different stiffness, and I have them available in 25 different sizes. But I think between companies, like I think the ATEC cage is probably a different stiffness than the Orthofix, which is different than the Stryker. So you have to ask them what the different stiffnesses are, and I think that's very real. Yeah, PEEK is still probably the best, but I don't think there's enough on-growth with PEEK. So I use PEEK like for 5 years after the allograft, and then for the last 3 years I've been using metal.
Brian, just one of the things I've noticed with standalones is I'll use them above a few
adjacent level.
And I like that because I don't have to go take the plate off. Right?
No,
So
that's where I used them, and they all fell into kyphosis.
Yeah, and I think the other frustrating thing too with them is there's, at least the companies I've used, they're like with my titanium cages, I can size that to perfectly fit what I want. But with the integrated screws, the sizing on that, you never really get what you want.